All right, welcome everyone. We're so excited to have you with us today. We'll give everybody a second to kind of load into the Zoomosphere here and we'll get started. So, welcome everyone to the fourth webinar of our 2025 webinar series, Mastering Lewy Body Dementia Together. My name is Julia Wood. I'm the Director of Professional and Community Education here at the Lewy Body Dementia Association. So for this year's theme, we are exploring a range of topics to help you better understand Lewy body dementia and its symptoms, strengthen your ability to advocate for services and support, and pick up new tools and techniques to help you live optimally. Let's see if I can get these to forward. There we go. So our mission here at the Lewy Body Dementia Association is to optimize the quality of life for those affected by Lewy body dementia. In order to do this, we accelerate awareness, advance research for early diagnosis and improved care, and provide comprehensive education and compassionate support. So a few technical items here to help you navigate the webinar. You can launch closed captioning, and by selecting the show captions at the bottom of your Zoom toolbar at any time during the presentation. There is also a resources icon on that same Zoom toolbar that has links as well as downloadable resources to accompany today's session. If you would like, you can print the webinar worksheet included in those resources to guide you through how to apply today's information. You're encouraged to submit your questions throughout the presentation using that Q&A icon. Following the presentation, we will address as many questions as we can from the audience Q&A pool. My colleague Rose will be dropping links into the chat throughout the presentation, and these links will also be in your email inbox in about 1 week from today as part of our post-webinar thank you email. This presentation is being recorded, and an email will be sent to those who registered with the link to view the recording in about 1 week. When you leave the session today, a brief survey will appear asking for your feedback about today's webinar, and we would greatly appreciate it if you would take a moment to complete that survey and help inform our content for the remainder of the year. And you don't have to wait for webinars. You can keep learning until our next webinar with our on-demand learning options. Recordings of all of our past webinars can be found on our YouTube channel, LBDA TV. Also, our Lewy Learning Center, if you haven't created an account yet, offers a variety of courses on topics that you can watch, rewatch, and share with friends and family. Also, you can visit our Mediflix channel if you would like to watch the film Spark about Robin Williams' battle with Lewy body dementia, and also recordings of other videos and webinars. And we encourage you to join our online social media channels to hear about coming LBDA webinars, programs, and events. And of course, please visit our website at LBDA for all of your other questions and LBDA needs. All right, with that, I'm going to stop sharing here. And now we want to learn a little bit more about who is with us in the audience today and what your experience is with Lewy body dementia. So Rose is going to launch a polling question that you can answer on your screen. So here you'll notice we're asking how long you've been either living with LBD, right? That could be a care partner or a person with symptoms. If you're a clinician, maybe how long you've been treating. If you're a researcher, maybe how long you've been learning or advocating. And so we want to kind of get an idea of how familiar and how long you've been living with Lewy. All right, we'll give you a second here to finish this one up. Excellent. Looks like we've got most of you coming in around 0 to 3 years. So a little bit newer, which we would expect maybe with our Parkinson's folks. All right, so let's share. So yeah, definitely 80. It looks like about 64%, 0 to 3 years, about 23% of you, 4 to 8 years. We've got about 8% of you that have a PhD at this point. You're been in it 9 to 15 years. And then more than 15 years, we got about 5% here. Excellent. Thank you so much for taking time to complete that. So now one more question, and this really helps our presenter know a bit more about the audience. So, how knowledgeable do you feel with today's webinar topic? This is kind of a new one for us at the Lewy Body Dementia Association. We are honoring Parkinson's Awareness Month, and so we're going to be talking specifically about Parkinson's disease dementia. And so, you'll notice here we're asking you, maybe this topic is completely new to you. We get hear a lot of you that don't really understand PDD and DLB and all of the alphabet soup that comes along with it. The next option here is I know a little bit about the webinar topic. Some of you may feel very knowledgeable, especially some of those that are in that 15-year range, or you might consider yourself an expert. We may have some researchers or clinicians here. Excellent. Those are just about done. Thank you so much. So it looks like we're hovering. Most of you feel like you know a little bit about this webinar topic, about 73%. We've got about 18% of you that this is pretty new to you. So welcome. We encourage everyone to join us and learn. About 8% of you are feeling very knowledgeable. And then we've got only 1% that feel like you're an expert. And I've got to admit, Dr. Goldman would probably agree with me too. I've been in this space for a long time and I don't feel very expert a lot of times. It is definitely a moving target. All right, and so with that, I want to introduce our presenter for today, Dr. Jennifer Goldman. So Dr. Goldman is a movement disorder neurologist with specialty certification in behavioral neurology and neuropsychiatry. Her clinical and research work have focused on cognitive and other neuropsychiatric issues in Parkinson's disease, Lewy body dementia, and other movement disorders. Dr. Goldman is currently the chair of the Lewy Body Dementia Association Industry Council and joined the LBDA Board of Directors in 2024. Dr. Goldman is an adjunct professor at Barrow Neurological Institute and provides professional expertise through JPG Enterprises, LLC. Please use your reactions at the bottom to give a warm welcome to Dr. Jennifer Goldman. Thanks for joining us.
Thank you so much, Julia. Shall I go ahead and share my screen?
Absolutely. Go ahead and share your screen. And then once you're all set up and feel comfortable, then I'll back out.
Okay. And let me know if you are seeing the
That looks
full
perfect. That's the
screen or I
correct
need to
view.
swap it. That's the correct view.
Oh, you're at the
Okay.
yep, you're at the first screen, correct view, and they are showing you lots of love. All right. I'll see
Oh,
you for Q&A in
fabulous.
a bit.
Thank you so much. Well, it is so nice to be with you all today and be able to share some knowledge and insights about Parkinson's disease dementia and Lewy body dementia in general, and hopefully help clarify some of those confusing terminologies that Julia alluded to and give you some pearls of wisdom for questions to ask about and tips and tricks to navigate your journey, whether you're a person living with Lewy body dementia or a caregiver. So this is the title of my talk for today, Navigating Transitions, Understanding Parkinson's Disease Dementia to Guide Discussions with Your Doctor. And I'm going to talk a little bit broadly too about cognition in Parkinson's and Lewy body dementia, but also to also think broadly. These could guide discussions with not only your doctor, but other healthcare professionals, perhaps people in the family or community, or with some of the associations like the LBDA that can help provide knowledge. These are my disclosures. Julia mentioned some of the work I do with LBDA, and I'm really privileged to work with this wonderful group. So these are the topics that I'll cover today. We'll talk a little bit about understanding Parkinson's disease dementia and dementia with Lewy bodies. You'll see some abbreviations for PDD and DLB just because they get to be a bit of a mouthful to say. We'll talk about how to recognize and assess cognitive changes in Parkinson's. I'll talk briefly about management for cognitive impairment, and that might be a whole nother webinar unto itself. And I do want to spend some time talking about effective communication with healthcare providers and give some tips and tricks and ideas that might be useful to you for working with your healthcare team. And then talk a little bit about resources and support for people with Parkinson's and their care partners. So first and foremost, and I think many of you joining us today are probably like-minded in knowing that knowledge is power. It is wonderful to see people actually early in their journey too, because this is a prime time to educate oneself and one's family, and sometimes even one's providers about the topic of Parkinson's and Lewy body dementia. And so this knowledge, I hope to arm you with some resources and background, because accurate and information is really important. And I know people take in knowledge at all different levels and in different ways. So this may be a resource that you can come back to look at or jot down notes and revisit over time. The other aspect I want to talk about is we're talking about cognition and dementia. And as Julia mentioned, my background is not only in movement disorders, but in behavioral and cognitive neurology. So I've spent the past 20 plus years working in this field on talking about areas that are often not as talked about as some of the motor symptoms, and particularly mental health issues, which carry often a lot of stigma and concerns. So I like to talk about the taboo and talk about things that are often very difficult, and hopefully break them down to approach them from a very non-judgmental way, normalize that we should be talking about cognition and behavior, and that these are part and parcel of care for someone with the diagnosis of Parkinson's or diagnosis of dementia with Lewy bodies. So we're going to X out the taboo here. So just as a way of background, since many people may be new to the field here, we use the term dementia as a big, broad umbrella to describe a range of symptoms associated with cognitive impairment. Now, these are changes that happen gradually over time that affect someone's cognitive abilities to the point that it interferes with everyday activities, their daily functioning. Whether that's work or hobbies, making decisions, balancing a number of cognitive tasks. Of the dementias, we often may hear of Alzheimer's as probably being the most common dementia form of dementia that is out there, but it's not the only cause of dementia. Some people have up to about a third or so vascular reasons, so they may have small mini strokes that accumulate in the brain. There's a small percentage of people that have a condition called frontotemporal degeneration related to the different areas of the brain that have undergone neurodegeneration. And then there's Lewy body dementia, and that's what we're here to focus on today. That represents about 10 to 25% of all dementias. And sometimes we've likened this to the most common dementia that people have never heard about. Again, another topic that we're trying to break down some barriers. Lewy body dementia has its own umbrella, which includes both Parkinson's disease dementia and dementia with Lewy bodies. And so these are both uh, under the umbrella of Lewy body dementia, or LBD. And I'll explain a little bit why that is so. Now, this is often where sometimes that confusion comes about, where someone might be diagnosed with Parkinson's and then later develops cognitive changes after they've had long-standing motor symptoms, tremor, walking or balance difficulties, slowness, and then they later develop cognitive changes and dementia. We call that Parkinson's disease dementia, based on criteria that were implemented over many decades and last revised in 2017. However, if someone first develops the cognitive symptoms, or very close in time then develops the dementia plus some Parkinsonism, they've been diagnosed or called people with dementia with Lewy bodies. And often there's been this somewhat arbitrary rule of 1 year of whether someone starts with motor symptoms or starts with cognitive symptoms to delineate the two conditions. Now, I'm going to share that there you have many, many overlapping symptoms, and that there are many reasons why they are closer closer siblings than farther apart on the family tree. So they have many overlapping symptoms and systems and features that affect cognition, sleep, like acting out of dreams called REM sleep behavior disorder, behavioral changes that might include depression or anxiety or apathy, motor changes such as a tremor or slowness or walking difficulties, sensory changes such as vision or decreased or loss of smell, and then autonomic changes that can affect the blood pressure with low blood pressure or lightheadedness upon standing, bladder, bowel, and sexual function as well. Now, to differentiate Parkinson's disease dementia from dementia with Lewy bodies and also from Alzheimer's dementia, this is just one type of table that illustrates a couple different features and when we typically see them across these three entities. So I talked a little bit before where when we have earlier motor features and then later progression into cognitive changes in dementia, we think of that still under the terminology of Parkinson's disease dementia. In Alzheimer's, dementia is one of the core features and an early feature. People with Alzheimer's generally don't have the same type of motor Parkinsonian features that we see in PDD or DLB. There are also differences in the type of cognitive symptoms someone might experience. So when we think in Alzheimer's, we think about memory, forgetfulness, difficulty with learning new tasks or remembering what someone did in the short term, trouble with language. Those are less common, although they may occur, but less common in both PDD and DLB, where we more commonly see changes in attention and concentration, executive function. So that's planning, processing, multitasking, shifting from one task to another, as well as in visual spatial function, so navigating one's environment. We more commonly may see visual hallucinations, so seeing things or in other modalities that are not really present in the environment, but seem very, very real to that person. We rarely see them in Alzheimer's. And again, there's a difference where we may see fluctuations in cognition, most commonly in DLB, but also present in PDD, but uncommon in Alzheimer's. And these are occurrences where people may have periods where they're really clear cognitively, but then they may have periods of confusion that follow, which could be days or weeks or variable time degrees, and they kind of wax and wane in that fluctuation. Now, there are also biological overlap and differences, and this is a very hot area in research and therapeutics these days. So where PDD and DLB share neurotransmitters and neuropathology of a brain chemical called dopamine, and also neuropathology that we see under the microscope called alpha-synuclein, which we see again only under the microscope where it may aggregate or clump together as a protein. Those are more characteristic of Lewy body dementias. Alzheimer, on the other hand, has greater degree of amyloid or tau deposition, often acetylcholine or cholinesterase changes. Although what we've noticed is that there can be an overlap between DLB and AD, and to some degree in PDD, where there may be additional neurotransmitter changes in acetylcholine plus dopamine, hence some of the medications we use to treat dementia, as well as the presence of amyloid pathology in the brain. And this may show that there are some overlapping features that ultimately might guide treatment decisions. Okay, so let's talk about cognitive changes in Parkinson's. So in the literature over the past couple decades, the estimates of how common this is really vary. We do know just on average that mild cognitive impairment, so not to the point of needing dementia, but having some mild symptoms or changes in cognition that don't fully affect everyone's day-to-day activities, can occur in about 25 to up to 50% of people with Parkinson's diagnosis. We've also learned over the years that sometimes these mild symptoms can be present in early stage Parkinson's when someone's newly diagnosed, and not only later in the course of someone's Parkinson's. And that's important because it's really changed how we think about Parkinson's and our goals to intervene early, identify people early so that ultimately we can slow down cognitive decline. On average, about 40% of people with Parkinson's may develop more severe deficits, which we call dementia. This increases with longer durations of Parkinson's and more advanced Parkinson's disease. Now, one really important topic that I need to mention is that not every person with Parkinson's develops cognitive impairment or dementia. While this may happen in many people over time, it is not a universal. And we still need to figure out and understand why that is. Why are some people more resilient than others? And we don't fully know that answer to that yet, but it may be quite informative from a treatment and planning basis. All right, so in the knowledge is power scheme, it's important to know the symptoms. So I'm going to talk a bit about cognition and cognitive changes to help outline what we see in Parkinson's disease as well as in dementia with Lewy bodies. So first and foremost, what is cognition? So after many years of studying Latin, I still come back to this, and we know that cognition comes from the Latin root to know. So it's really the mental actions and processes of how we acquire knowledge, how we understand the world through our thought, our experience, and our senses. Often people think of cognition, they jump to memory. And people may also say, oh, my memory's bad, or I'm having trouble with my memory, when they really mean some other aspect of cognition. So it's an important takeaway that cognition does not equal memory per se. There's a whole bunch of different cognitive processes, some of which are listed here. So attention, working memory, which is holding something in one's head while doing something else. So keeping track of that phone number while you go write down a list of groceries. Language, problem solving, decision making, reasoning, judgment, comprehension. So not only what we read or what we hear, and then of course, learning and memory. So what are some of the common symptoms in cognition that we see in Parkinson's? I mentioned before that memory and language are not as commonly affected in Parkinson's or dementia with Lewy bodies as they are in Alzheimer's. So most commonly we see changes in attention and working memory. So that might be trouble concentrating, trouble keeping track of information in one's mind, difficulty with planning or organizing or initiating activities or multitasking. And particularly in the world of multitasking we live in these days, people may experience difficulty stopping and starting tasks. So changing activities, shifting from one task to another. These are the most common, so attention and executive function, and they include specific areas of the brain that are involved. Very often the frontal areas and the basal ganglia, which we see affected in Parkinsonian conditions. There may be some language difficulties, which generally manifest as trouble finding words or naming. Sometimes hard to distinguish to, getting older and having that tip of the tongue phenomena. Sometimes people may have reduced fluency of their speech. So sentences are shorter. There's less content in each sentence. There may be trouble with memory, although again, this is less common compared to Alzheimer's, where people may have difficulty learning a new task or recalling facts or events. People may experience difficulty with visual spatial function. Again, these all have different parts of the brain that are involved, where their sense of direction might be impaired. They might have difficulty drawing different types of objects and so forth. But cognition and cognitive changes in Parkinson's is really a spectrum. So it changes, if they happen, occur gradually over time. They don't happen overnight. And this may be, years in the making. At the least severe level, people may experience what we call bradyphrenia, which is basically slow thinking. We think about bradykinesia, if you've ever seen or had this done in your examination. This is, we check this for slowing of movement. Bradyphrenia is sort of the equivalent of slower thinking. There may be people who have mild cognitive impairment or dementia. And so there may be a spectrum from PD, no cognitive impairment or normal cognition, to PD MCI or mild cognitive impairment, to PD dementia. And often that is determined by the degree of how it affects someone. What is their change in functional ability, and what behaviors and abilities are affected by cognitive changes. We also know that there's a spectrum of the different types of cognitive areas that are affected. On the prior slide, I showed several different cognitive domains, and it doesn't mean that all of those are affected. Some people may just have one that's more affected, or one that's more affected than another. And we call that single domain versus multiple domain, where there are multiple areas affected. So again, this cognitive impairment has a lot of nuances to it. So hopefully this is breaking down some of those items for you all. So what are some early indicators of cognitive decline? They may include slower thinking, sometimes losing one's train of thought easily, changes in attention or concentration, like in a conversation or reading a book. I mentioned before, trouble keeping track of more than one thing at a time, and difficulty in multitasking. There may be some subtle memory loss. And additionally, there may be some other features that we often hear from patients. They might have trouble seeing, but the eye doctor says there's nothing wrong with their vision. They may have trouble finding an item in a busy or cluttered area. So kind of searching for something amidst, a lot of similar looking or a lot of objects, or difficulty with visual tasks. And this points to that visual spatial changes, which are often less recognized or appreciated than some of the others. So what about the progression of cognitive changes? Well, I mentioned before that there's a spectrum, and potential changes from normal cognition to mild cognitive impairment to dementia. But that course is actually highly variable. It's not always a linear path. And what we've learned from a variety of studies that have followed people with Parkinson's over, several years, 3 years, 5 years, 10 years, with usually annual cognitive assessments and other evaluations, is that not all people with PDMCI progress on to dementia. And so one of the things that we've tried to understand is, why is that? Why do some people progress to dementia? Why do people stay and have PDMCI for the duration of their Parkinson's? And why does a subgroup of people improve in their cognition and revert back to more normal cognition on testing? Now, this may be influenced by many different factors, including many that we actually don't fully understand to this day. But there may be different clinical features, so different types of cognitive changes might progress more quickly than others. There may be coexisting medical issues people have. So in the setting of other medical comorbidities, high blood pressure, diabetes, other vascular changes that might not be well controlled. And there may be some underlying genetics where there are people who have specific genes that make them more susceptible to developing dementia or neuropsychiatric issues in Parkinson's. So in terms of the risk factors, the two that I've starred are probably the most that have evidence in the literature. So one is older age, and the other is greater severity of motor symptoms. So, we always think, okay, for risk factors, are there things that we could do to modify these or change the course? Well, age is a little bit of a tricky one, but we do know have interest in lifestyle modifications and other things that can affect cognition that we can control. The other risk factors is having a baseline cognitive impairment or PDMCI, so that already the presence of cognitive impairment might be a risk factor for cognitive worsening. Several of the others have come up in literature, but are not I, fully understood. So being older when someone develops Parkinson's, having longer duration or time course of Parkinson's, having more stiffness and rigidity and slowness compared to tremor, having the presence of hallucinations or depression, or certain genetic forms as listed below. The other important piece is to recognize that many factors can affect cognition. So sometimes there's a tendency to attribute all symptoms to Parkinson's, and that might be correct and accurate in many ways, but it doesn't always mean that everything is related to Parkinson's. So there may be other reasons someone can have cognitive impairment or cognitive changes. I've listed a few of these on this slide, and of course there may be others, but someone could have medical illnesses. They could have depression or anxiety or apathy, which may go hand in hand with cognition, but sometimes if someone's so depressed or so anxious, it affects their thinking and their mental health, and also their performance on some of the cognitive tests. Sleep disturbances. I think we all can attest that if we haven't slept well one night, we don't feel as sharp and with it the next day. Medications. So always important to review medicines, because there are some that can aggravate cognition and so forth. Impaired hearing and vision. So again, as we get older, these are important areas to screen, because if we can't get the information in, it makes it even that much harder to remember or process. Other neurologic conditions like head trauma or seizures or mini strokes can affect cognition. And then in some people, and this is probably a whole topic unto itself, deep brain stimulation, which is used to treat Parkinson's, may have some relationship with cognitive changes in some people. Okay, so when should we assess cognition? I already shared at the very beginning of the talk, one of my personal philosophies is that we need to think about this, addressing cognition, evaluating cognition as part of the care of Parkinson's. It is part of comprehensive care and high quality care. So in addition to looking at motor symptoms and testing for fine motor and walking and balance and falls, we as healthcare providers should be asking about cognition and behavior and mood and autonomic symptoms and all those other bubbles on that early slide I showed. There are different ways to assess cognition, but it should be part of the conversation in part of Parkinson's care, from being newly diagnosed in early stages to advancing Parkinson's. So basically throughout the whole course of Parkinson's is important. It may be helpful to have a baseline assessment to know where someone is, where are they coming from? And this varies from person to person based on everything they bring to the table. Their their education, what they do for a living, their medical history, their genetics, all those, their Parkinson's, all those file into a baseline evaluation. And it's important to follow over time. We follow motor symptoms over time and make adjustments in medications or rehabilitation therapies. We should think a little bit like that too for cognition. Other certain scenarios of when to assess cognition is if someone or someone else is noticing changes. If someone's having trouble with work or school, hobbies, activities, driving, and so forth. So if something's different and there's a trend for this to be different, it's worth looking into. If there's safety concerns, whether that's related to driving or judgment or different types of jobs, that could be um, a, a perfect reason to look at cognition. And then in planning. So planning, another often taboo topic that comes up is advanced care planning. The question of, if I can't make decisions for myself, what would I want someone to do to respect my wishes? And that's often a very difficult conversation, but cognition plays into that as well. I mentioned before some of the research that we would like to be able to identify people early for cognitive changes, so that when we have medicines and techniques that we know can slow down cognitive decline, we can implement those. So there are also research opportunities for clinical trials and other studies to help understand cognition and hopefully help improve the symptoms as well as slow it down. So how do we make a diagnosis of cognitive impairment, whether it's MCI or dementia? Well, as healthcare professionals, we rely on a number of different reports. So what a person living with the disease says, the patient, an informant, which could be a friend, a care partner, spouse, other person, to get some, other information, what we observe as a clinician, and then objective evidence from testing. And then over the years, there have been diagnostic criteria that we have developed for dementia with Lewy bodies, for Parkinson's disease dementia, for PDMCI. One piece that's important to think about is interpreting these cognitive changes in context. So we all come from a different baseline. And so sometimes this makes it a little bit trickier to interpret different types of testing. So to me, it's always it's the whole picture. It's not just a score on a cognitive or neuropsychological test. It is the background of that person, their education, all the things that make them who they are, and where there has been change. So sometimes if someone tests normal, it may still represent a change for them, but they may be coming from so high high up that their scores are still within a normal range. So it's always important to just put the whole context in the picture. So who might be involved in assessing cognition? And those of you who may know me, I'm a big proponent for team care in Parkinson's and Lewy body dementia and other movement and cognitive disorders. So I think all of us to some degree can be involved in assessing cognition. We might do it differently and in different settings. Most commonly, you might hear about this being done by a primary care, internal medicine, or geriatrician, or neurologist, which could be a movement disorder specialist or a cognitive or behavioral specialist. Sometimes it might be a psychiatrist or a nurse working in some of these medical subspecialties. Often these tests are what we call kind of bedside or global cognitive tests. They're short, maybe take between 5 to 20 minutes, and give a snapshot of cognition. To do a deeper dive into cognition, often someone is referred to see a neuropsychologist who might work with a psychometrician who's really the tester, and put together a more formal battery that tests those multiple cognitive domains. It might last anywhere from 45 minutes to several hours, depending on the tests and the centers and the purposes. And they issue a report and work with the neurology team to help interpret and provide that information. However, cognitive assessments can also occur in our rehabilitation settings, in psychosocial settings. So a social worker might ask questions to gain a sense of cognition. Speech language pathologists or speech therapists work quite a bit with communication and cognition. So not just speech in terms of articulation and vocal output. Occupational therapists work a lot with cognition and day-to-day functioning. And a physical therapist might work on cognition in terms of that dual tasking or multitasking. So walking and talking and thinking. So again, we all play a role in this. As I mentioned, there are many different types of cognitive tests. There are ways to look at all of these domains in aggregate with global tests. There are neuropsychological tests that have been developed to look at each one of these individually. And there are numerous types of tests out there in the literature. Some of these are done by pen and paper. Some of these are computerized. And again, they range in the time and the location and the resources available. It's often hard to think about cognition without thinking also about function. And function is what we do every day to go about our daily activities. And this is often the turning point or the critical point in moving from mild cognitive impairment to dementia, where there's a greater degree of cognitive changes that have built up that really affect how someone functions in their day-to-day activities. There are two types of function that have been developed in the field or thought of during the field, and they include what we call the instrumental activities of daily living, or IADLs. And often this is something an occupational therapist works with patients on. And these often include, this is a short list, so there are many others that could be involved, but things like managing money, balancing a checkbook, managing medications, and we know people can have complicated regimens, using transportation, driving, getting on a bus or a metro, stopping for groceries, using a telephone or smartphone, day-to-day household chores. Those all fall under the umbrella of instrumental activities of daily living. Now, we recognize too that there are differences in who does some of these, often in a relationship, and generational differences. So this is a bit of a grab bag of activities that might be helpful to think of. Then there are basic activities of daily living, and these have to do with core activities like eating, bathing, getting dressed, toileting, transferring from a chair into the bed, or walking and moving around. So some of the questions we might ask, in addition to the cognitive changes, are really how does this affect one's ability to do these different activities? And this might be something I'll talk a bit about, bringing up examples to your doctor or healthcare provider, that linking them to the functional element is often a really useful example. I have noticed that I've had trouble doing X, Y, and Z, and so forth. So again, I'm going to talk very briefly on some management of cognitive problems, only because this could be a whole talk unto itself. But just to highlight from the healthcare provider and doctor perspective, we often think about getting the data that I mentioned. So understanding what the cognitive changes are, what objective data on testing there is. But then we also think about, how do we rule out other causes, especially if the changes are acute. So someone might have an infection, a urinary tract infection that's causing cognitive changes or hearing loss. It's really essential that we review the medications that someone takes for Parkinson's and other reasons, and reduce or eliminate any that might be clouding cognition, such as like pain medicines or sometimes sleep medicines or bladder control medicines. We may want to consider medicines for dementia. And I just noted that there is one that's approved in the United States by the FDA called rivastigmine. Its other name is called Exelon. And there are also two others in the same category of medicines that work on that chemical I mentioned way back called acetylcholine. So they work as cholinesterase inhibitors. There's also another medication that has been studied in PDD and DLB called memantine. And again, these would be reasons to talk to your doctor about whether medicines are appropriate for you and your care. One caveat is they are not approved for PDMCI, but more approved for the later stage where we talk about dementia. Also really important is to think about non-medication strategies. And I mentioned some of the rehabilitation therapies that could work on communication strategies, cognitive training. We know physical exercise can be so helpful in motor and non-motor features, and working with psychosocial services, whether it's a psychologist or social worker or counselor, to help cope and manage with cognitive changes. Driving may need to be assessed. Often there are occupational therapy departments that will look at driving and road tests and looking at what someone might need to have for adjustments or accommodations in work or safety, and of course the impact that cognitive changes may have on relationships. I do just want to make a word about healthy lifestyle habits. Many of these, we don't know exactly how they work or whether or how much they do work, but there's great interest in looking at these to slow or prevent cognitive decline or help maintain a good cognitive outlook. And so just a plug for thinking about these in day-to-day life. Exercise, restorative sleep, positive social connections, stress management, healthy eating, and minimizing risky substances such as drugs and alcohol. Okay. Also coping with stress. So we know stress can affect cognition in different ways and mental health. So there are numerous ways to think about coping with stress. So I wanted to just touch a bit on the importance of effective communication. So how can we guide to talk with one's doctor or healthcare professional? And this is a two-way street or a multi-way street, but it's really important for healthcare experiences to have education and understanding to enhance our relationships. And I think incredibly important to empower people in their own healthcare management so that together we can have better health outcomes. There's literature on um, effective communication leading to better outcomes. So there are studies that show it enhances not only satisfaction and compliance, it improves social, bodily, and psychological health. It helps people feel like they're more in control. And it helps with building trust and greater satisfaction. And I think when we talk about effective communication, we need to talk about both verbal and nonverbal communication strategies. All right, so I know many of many of us have been in a situation at the doctor's office where they're saying one thing and it just sounds like a bunch of jumble and gobbledygook in one's head. So this is the cartoon of what the patient heard and what the doctor meant to convey. So again, a two-way street on clarity here. And then often it's not what you say, John, it's how you say it. So these are challenges that can occur in communication. They're not the only ones. And when I think about this, every challenge becomes an opportunity. So we all know these from the healthcare system. People may talk a lot in medical jargon. There may be cultural differences. We know these are difficult topics to talk about and weighty from an emotional standpoint. There may be hearing impairments, language barriers, time constraints we're all too familiar with in the healthcare system, as well as long time between appointments, and many others that are listed here that are important and challenge our communication both ways. However, to have successful and effective communication, I do think there's some pearls that I hope to share with you today and help fill your toolbox. So again, recognizing that these are difficult conversations, talking about cognitive changes, decline, dementia, there can often be a lot of emotionality to it. There's concern about loss and grief and sadness and anger. And it's important to recognize these and know that these are normal and appropriate reactions to talking about cognitive changes. It's important to be proactive, but I also think what one can take this slowly and in different steps. So not everything happens to happen in one appointment or in one fell swoop. And there are different tools that can be available. Some of these actually borrow or come from the advanced care planning guides that help with having difficult conversations. So a few strategies that I wanted to put out there for food for thought. One is being prepared. So having coming to an appointment with some sort of documentation of changes in cognition or behavior, because that really helps facilitate the discussion. This could be examples. This could be notes. It could be just observations, but having that already top of mind goes a long way. It's important to bring a list of medications as well. I also think on the preparation side, it's helpful to plan to set aside this time in the appointment for talking about cognition or concerns or issues that have been noticed. And this could be done in any number of ways. So even a message through the electronic medical record system to the doctor or provider, hey, I'd like to talk about this in our next appointment, or a note upon check-in, or when you sit down in the office visit. Too often, these topics come up, really important topics come up at the end of the visit, and someone's about ready to leave, and there's just not that time or space to do justice to them. Effective communication. So, to one's best ability, being able to clearly articulate what the concerns and changes are noted. I think providing examples are helpful. When was this noticed? What was noticed? How has it affected someone? Asking questions, and then also understanding, getting feedback to prevent being that cartoon where a bunch of jumbled information is heard. So this could be repeating something back or asking for written information. I always think it's helpful to have another person, often another pair of eyes and ears, to process the information at a visit. I think there are opportunities for the healthcare professional, and I'm just kind of wearing that hat now, to be able to take the time to have empathy and explain the diagnosis and provide information in a coherent and empathic manner. I think it's also important for us to assess someone's understanding and then have follow-up communication. As I mentioned before, normalizing talking about cognition and behavior so that it's part of Parkinson's care and recognizing its importance is essential. There are even a couple models that have been taken from different areas and used in the healthcare world. One is called the Spikes model, which is really about setting this up and allowing that time and space to have these conversations, assess where someone's at, invite the person to receive the news, particularly if it's a new diagnosis or talking about dementia, provide the facts and explore emotions, and then revisit this and make sure someone understands the treatment plan and situation. So again, I wanted to share just a few possible questions that in communication one might think about asking. I am listing them here. I'll just read them out just a little bit. But how does a person have their cognition assessed? When should I look into this? When in my diagnosis should I start, having even a baseline assessment or a global assessment? How do you know that I have cognitive impairment? Do I need more testing? What do we know causes cognitive changes? Do any of my other medicines affect my cognition? What should I look for in a PD care team? Am I going to be prescribed medicines? What do medicines do? What are their side effects? What should I know about exercise and rehabilitation therapies for cognition? How might these changes progress? Are there other people with whom I can talk? What research is being done, and are there clinical trials for me? And again, sometimes these questions come up just if this is top of mind, wanting to know more, think about the future. Sometimes they come up when there are actually changes occurring. So there are a number of tips and tricks, I think, when someone has cognitive changes or cognitive impairment. And I always encourage people to think outside the box. So what works for one person might not work for another. And there's a lot of room for creativity. So simple things, like lists, pill boxes, medication reminders, all work really well. There can be more technologically advanced adaptive equipment or augmented technology. We might, turn to Alexa or Siri or some of these other tools to use. There can be cognitive and physical exercises. There can be sensors and devices, the games on one's phone, real-time monitoring using various apps and so forth. And of course, occupational therapy often has very robust resources. I also think it's important to focus on preserved strengths. So we often talk about cognitive decline and impairment and kind of a very deficit or focused model. And what I think is critically missing is that we don't focus on what someone can still do, their preserved strengths, rather than what is, lost or changed. So just because someone might have trouble in one area doesn't mean they have trouble in all areas. So we need to ask ourselves, what can someone still do independently and safely? What might someone need some accommodations with, and what might someone need more assistance with? So we need to reframe this and think about preserved strengths, skills, and abilities. And same with the neuropsychological testing. So it's not uncommon after having had this whole battery of tests for someone to feel like they failed on a test or be very anxious about it. And we know from years and years of doing neuropsychological tests in children and school-aged kids and adults is that everyone has strengths and weaknesses. So what we need to think about is, how do we maximize those strengths? And how do we think about compensating for any weaknesses? A few words on communication strategies, and then I will wrap up, and happy to take some questions. Just particularly in Parkinson's and in the setting of cognitive impairment, it may be helpful to socialize in smaller groups and limit distractions so someone can be more face to face to have better communication. Speaking clearly and slowly and with simpler language, or presenting more concrete rather than abstract ideas. Often people do better when given choices, so rather than having to recall multiple options. So that might be another technique. There also might be good help in doing making to-do lists, as I mentioned, having activities, maybe plan something, one activity for each day, or however many times a week. Lastly, I wanted to mention just building your care team. So I think a team approach is important in Parkinson's because it is really a multifaceted disorder where there are many different types of symptoms. As professionals in different disciplines, we each have complementary but different expertise that we can lend to have a more comprehensive treatment plan. And of course, because not any one person can do it all, spreading out the care across a team may have benefits for managing healthcare systems and then really enhancing quality of life and function. Making sure the team communicates, coordinates, and collaborates is also really important. And I just wanted to leave some thoughts for the caregivers because this is an important aspect of guiding care and navigating care in Parkinson's as well as dementia with Lewy bodies. So knowing that being kind to yourself too and taking time for yourself helps make you a better caregiver. So building in breaks, creating your support system, sharing and expressing your feelings, and getting the education and support that's needed. I think it's also an important aspect to recognize that sometimes it's the disease talking and not your loved one, and that some of these changes are not the core of the person, but it's really manifestations of the disease that come out, particularly sometimes when we're talking about behavioral changes. And I'm a big fan of cherishing moments and practicing gratitude. There are many resources and ways to connect. I know the LBDA in their website and through their educational programs and helpline and educational programs have ample information that you can access. But also thinking about books and websites and people on the Parkinson's team, support groups and community networks, whether in person or virtually, as well as other advocacy groups, really can be informative and help shape this roadmap. Lastly, I want to emphasize that I know I'm talking a lot about some heavier topics and cognitive impairment and dementia, but in neurological diseases, it is so important to keep up hope. We get smarter every day and research advances, and we have new therapeutics that that we work on and hope to bring to the patient community. And lastly, no matter where someone is in their journey, whether this is the beginning for you or the middle, or you've been diagnosed for a number of years, there's always something to do that we can, there's always something that we can do to help. It might look different at different stages, but there are different techniques and management strategies to help person living with Parkinson's or Lewy body dementia and their care partner along the way. So thank you. I will take a look at the questions and chat with Julia, and really appreciate your joining us today.
Thank you so much, Dr. Goldman. That was incredible. Really appreciate you taking the time, and they're showing you lots of love there. Excellent. Thank you for such an
Thank you.
engaging presentation and for taking time out of your day to be with us. And so I'll let you stop sharing your screen, and then we can come on and take some questions.
Wonderful.
Excellent. Okay.
Great. Okay.
Fantastic. So you're welcome to look at the Q&A as well. We have a question I think we can start off with. Someone asked, does it matter if you're diagnosed with Parkinson's rather than DLB? I know there are a lot of times, people, because of some of the confusion around diagnosis, a lot of times people maybe don't get the right diagnosis. They Parkinson's at first and then later Lewy. So does it really matter? Is that a big issue?
It is definitely an issue that we commonly face. And I think that's part of that confusion in the terminology. So often, well, I wouldn't say often, but sometimes we see that people have had a diagnosis of Parkinson's and then they move into the Parkinson's dementia or PDD stage. And somewhere in a chart or in a conversation, Lewy body dementia gets mentioned, or dementia with Lewy bodies, and someone questions, did my diagnosis change? And do I now have a different disease or condition? And I think one way to think about that is these are really on a spectrum, or close siblings. So they're sort of the two sisters, if you will. So there are a lot of similarities between Parkinson's disease, dementia, and dementia with Lewy bodies. So on one hand, many of the treatments and the symptoms that we would use, and the tools and the medications or rehab strategies overlap. So on one hand, part of me says, okay, the nuance in the definition may not affect someone's overall care or management strategies. However, we do know there's certain circumstances in someone, if someone has dementia with Lewy bodies and kind of the greater dementia piece, and maybe a little bit of Parkinsonism or no Parkinsonism at all, they may respond differently to several medicines, and may have more prominent fluctuations or other changes. And so in those settings, my hat is it may matter from a management strategy. But I think really getting clarity, it's important for people to have clarity about their diagnosis. It's also important for us to have a common language that is well understood by everyone. So hopefully that helps answer that question.
Absolutely. Thank you.
Okay.
It's very confusing even for clinicians, you guys, so you're not alone in this. A great question here, I think. Do you think that REM behavior or REM sleep behavior disorder is a symptom? If people have that, they're more likely to develop PDD or DLB?
It's a great question. And so REM sleep behavior disorder, just to take a step back, is the occurrence where people will act out their dreams during sleep, during REM sleep. So normally during REM sleep, we're still, we may be dreaming about fighting the lion, but we're not moving around in bed. When there are neurodegenerative changes that switch, that turns to a different way, so that people lose the atonia that we think of, and they may move around, so they might punch or kick or vocalize or think they are really fighting that lion, just as one example. And what we've learned about REM sleep behavior disorder over the years is that there's a high likelihood of people who have that in over years to develop what are called synucleinopathies. And so those are neurodegenerative disorders that have the buildup or the aggregation of that alpha synuclein protein that I mentioned before. We don't fully know kind of which road REM sleep behavior disorder always travels. So among those three synucleinopathies that can develop from it include Parkinson's, dementia with Lewy bodies, and another related but slightly different condition called multiple system atrophy, or MSA. So it's not entirely clear that having RBD increases the chances of having Parkinson's dementia, but it does increase the chances of having Parkinson's disease or dementia with Lewy bodies. What we are learning is that in people who have REM sleep behavior disorder, who may undergo testing for smell or cognition or other biomarkers, is that we're finding that they may have some subtle abnormalities already in those other domains, suggesting that this is maybe part of the neurodegenerative cascade, and really an opportunity, if we have agents to slow down these diseases, where we might want to target.
Absolutely. Really great discussion there. So a couple of questions here that I'm going to try to merge. So we get a lot of questions about stages, right? What stage of PDD someone's in? So someone asked here, does knowing the stage of PDD, is that important to care? And how do you know what stage you're in? And I think related to that, when do you know, or how do you know if someone's moving from mild cognitive impairment more into that dementia?
Oh, that's great. Great question. So one of the challenges in the field of Parkinson's and dementia with Lewy bodies over the years is a little bit, we have a very good staging system for the motor features. So you may hear about something called the Hone and Yar, named after two clinicians and researchers in a number of decades ago, which really looks at motor function and balance and walking. We don't have a great equivalent of that for cognitive changes in the Parkinson's and dementia with Lewy bodies world. In contrast, where Alzheimer's actually has a staging system that has been followed and linked to function and widely implemented over many years. So without a very robust or well validated scale that's been or staging that's been used, we tend to think of things along the lines of perhaps severity. So slight, mild, moderate, severe, or by a little bit on the duration of how many years of symptoms, 0, 5, 10, 15, and so forth. But with that said, one of the anchors that we've used in terms of the transition from MCI or mild cognitive impairment to dementia in Parkinson's, and similarly goes for Lewy body dementia, is when is there presence of cognitive changes in multiple areas? So it's not just one area, but several different areas of cognition are affected. So executive function and memory, or executive function and visual spatial function and memory. So some combination. And then where is it and when is it that it affects someone's day-to-day functioning to a sufficient degree that it's interfering, it's noticeable, it's not just there's a little something, but it's impeding someone's ability to manage their medications or drive or perform to their ability at work, or in hobbies. So it's partly the severity of the cognitive areas, but also the severity of how it impacts someone's day-to-day function.
Absolutely. And I have to thank you for giving such a shout out, as always, to occupational therapy. April's also Occupational Therapy Month. And you guys, when you think about what we do in addressing function, a lot of times, myself and my colleagues, we were the ones that would notice that in the team, because a lot of times the doctor might be looking at something really different in their visits, and then we're noticing those functional changes because we're having you make oatmeal or make pasta, which is not something the doctor's necessarily going to get to see you do. So thank you again for that. A question here that I think is really good. What are some good exercises for cognition? You kind of touched on that a little bit. Any recommendations?
Oh, sure. Well, I do think there's a whole field of co- cognitive training, cognitive rehabilitation that has a lot of good elements to it. It probably also needs more robust studies, the way we think about how we study drugs that get approved. But there are training programs that can work on individual elements of cognition. So some of these, can be good old pen and paper. Some of these can be apps or different things on your smartphone, that can have drills into paying attention or visual search. So I mentioned that trouble of finding an object in a sea of other objects. So training the brain to pick out those. There can be, some of these have been now gamified a little bit into executive function or attention, visual spatial. Language is often a good one. So, thinking of naming things in different categories. It reminds me of a game we used to play when we were kids of, different categories, and you'd have to name however many, I don't know, vegetables or, types of cars or what have you. Those keep the brain active and actually practice some of the areas that we know can be affected in Parkinson's cognition. Now, some of the questions with this always have to do with, if I train my brain in this area, does it carry over into other areas? Does it carry over into day-to-day function? And those are open-ended questions from a research standpoint. But those can be very helpful. There are speech therapists and occupational therapists and other even online programs that people can find these. There's also evidence and growing studies on the benefits of physical exercise. So getting moving, or incorporating brain games. Some of the boxing programs do this as well, and physical therapies where you're moving, but you're thinking or responding to different questions and problems, engage the brain and may help release, neuro neuro growth factors and other positive brain chemicals.
Absolutely. Well said. And you guys, I'll do you a solid, and in the resources we send out, I'll put in some of my favorite cognitive activities. And to her point too, with the movement, there's some research, I don't know if they've looked really hard at cognition with this, but if you think about ballroom dancing, tango, where you're having to like think and move and learn a sequence, tai chi, something where you've got to kind of move and think at the same time. And I think the really important element too is to have fun. I think that that's something we take for granted, is just really enjoying it. And we'll take one more question here. And I lost it. Oh, I think this is such a great question because you talked about, discussing this with your neurologist. And so this gentleman's asking, what questions can you ask your existing neurologist to ensure that they actually know this info or understand it? So kind of like, how do you get a little litmus test or quiz your neurologist, I suppose, to see if that's the person that can hear your complaints or your concerns?
Oh, that's
That's a
wow.
tricky one.
That um, I think like for any medical care, right? We all want the best for our loved ones, or ourselves as well. So some of that is us doing our homework. So, looking at someone's, practice, years of experience, training, specialty certification, although there isn't, a fellowship training because there isn't a certification for movement disorders per se, but looking at, what is their knowledge base. Word of mouth, I know always, I know there's often conversations among people in support groups and exercise classes, so word of mouth, although recognizing we all have different styles and personalities that you might click with someone else, and so forth. So there's a personal fit. And then, asking some questions, from a perhaps feeler standpoint on, when when should I, be concerned about this, or should we be doing other testing, or even I heard, I was talking to so and so in my support group and they were telling me about this, is this appropriate for me? And you may get an answer that no, don't worry about it, or yes, maybe let's think about it. But it's a dialogue, and again, things don't happen overnight. There's a process, and it's a relationship. But I think feeling comfortable with someone to bring up your concerns, and someone who can help advocate for you and also to advocate for yourself. So hopefully that helps. And knowing that there are many resources out there, and educational programs. Um, so
Absolutely. No, I think that's great advice. And you guys, I saw that all the time at our center, where sometimes even people wanted to find the most experienced, the person had been there the longest, and then they just didn't really fit from a personality standpoint. It's not that the person wasn't, really good. I think you're so right. It's who you feel like listens to you and who you feel comfortable talking with. Great, great advice. All right, you guys, with that, we'll wrap it up here. On behalf of the Lewy Body Dementia Association, I'd like to thank you all for taking time out of your day to join us. And again, I'd like to thank Dr. Goldman for sharing her expertise with us. As a reminder, you're going to receive an email in about 1 week with a link for the recording of the presentation, as well as the resources and links that we've shared today, and some other tidbits based on your questions that we think you might appreciate. We invite you to visit our landing page on the website to stay informed about our upcoming webinars and access past recordings. And Rose will drop that link in the chat for you. So coming up next, we're going to be talking about bridging the gap, ensuring palliative care for Lewy body dementia through advocacy and support. The live webinar will be on Thursday, May 8th, so a month away, at 1 p.m. Eastern Time. This will be an insightful webinar presented by Dr. Kevin Webb Kay, designed to support people with LBD. So now we know that's you guys out there with PDD and with DLB. We've got our alphabet soup or our equation down, and their care partners in advocating and accessing palliative care services. This webinar is a must attend for anyone affected. We're going to offer hope, guidance, and a sense of community. So don't miss this opportunity. So Rose is dropping a link to that registration page and also to the survey. So please take a moment to fill that out for us. And we will see you again in about a month. Thank you again, Dr. Goldman.
thank
And
you.
thank you all.